This is part 2 of a talk designed to get you comfortable with Doppler, with a focus on spectral waveforms. If you haven't watched part 1 yet, I strongly suggest that you stop here and watch part 1 before moving forwards. Part 1 covered the basic principles that you need to understand about Doppler, including how to look at a spectral Doppler tracing. In this video, we're going to go from head to toe and look at characteristic normal waveforms and then examples of the most common pathologies that you're going to diagnose with spectral waveforms. Although spectral waveforms can seem complex at first, for most of these we're just applying the basic concepts that we've already covered. It's going to get a little bit more involved when we talk about the liver because we have to introduce portal and hepatic vein waveforms. But regardless, by the end of this talk, you should be more than ready to interpret waveforms effectively. So let's get started. And so let's start up closer to the head. And so we have a few waveforms here, and we're looking at carotid arteries. And so these are all normal neck vessels. So we have the internal carotid artery over here. This is a normal ICA, or internal carotid artery waveform. So we've interrogated in the ICA, and you'll notice that it's a very low resistance waveform. So it's a low RI. There's a lot of end diastolic flow in a forward direction. Okay, and we'd expect this because the internal carotid artery is obviously feeding the brain, and we need it to always be feeding the brain. So we want a low resistance waveform in the ICA like this. Okay, the second picture here is the external carotid artery, or the ECA. And so the normal ECA waveform is a higher resistance waveform. Okay, so there's still forward velocity or forward end diastolic flow, but this is a picture of a relatively high resistance waveform. And then here we have the common carotid artery. This is proximal to both of these, and this is going to be kind of a combination or a mix of the two of the ICA and the ECA. Okay, and so knowing those, let's go through a case. So here on the left side of the screen we have the right internal carotid artery, and over here we have the left internal carotid artery. And at the top we're imaging at the proximal internal carotid artery, and distally we're imaging distal in the distal internal carotid artery. Okay, and so you'll notice here at the proximal right ICA, the peak systolic velocity is very high in comparison to the left side. And if you look distally as well, so now on the right distal ICA, the waveform looks very different than on the left as well. So on the left side distally, the waveform looks very similar to proximal. It's a low resistance waveform with a quick upstroke. Okay, here in the distal right ICA we have a slow upstroke. It's weaker. Okay, and also there's spectral broadening or broadening of this waveform as well. So this is a tardus parvus type of waveform distally in the ICA. So what's going on in this case? Well, if you understood those basic principles, you would know that this is what internal carotid artery stenosis looks like here on the right. On the left, it's normal. And the stenosis in the ICA is most commonly proximal, so that's what we're interrogating here. And so at the stenosis, we have an increased peak systolic velocity, and then distal through it, we have this tardus parvus waveform. So the diagnosis here is right-sided internal carotid artery stenosis. You see higher peak systolic velocities with greater amounts of stenoses. So we can quantify the stenosis based on the peak systolic velocity as well as some of these other measurements. And so don't memorize these numbers for now, but the principle here is that higher peak systolic velocities generally mean a higher level or amount of stenosis. So here, these are the criteria for a stenosis in the internal carotid artery that's greater than 70%. And so in our case, we had a greater than 70% stenosis in the right proximal internal carotid artery. And so what about other clinical situations in the neck region? So what if we had an intracranial only ICA stenosis? What would the neck internal carotid artery look like? Well, the neck internal carotid artery is upstream of the area of stenosis or high resistance, so we would expect an upstream high resistance waveform, so a higher RI. What if you had aortic stenosis? Well, if you had proximal aortic stenosis, then all of the neck vessels that we're looking at, including the internal carotid artery and the vertebral arteries, etc., are all going to be distal to the stenosis. So if you had severe enough aortic stenosis, all of the vessels in the neck are downstream from that, and they're going to look like a tardus parvis waveform. Again, this is just following the same principles that we talked about earlier. Okay, so let's move into the abdomen. So we'll talk about the abdominal aorta first. So this is a normal aorta. And notice, as we mentioned earlier, how thin the waveform is here. And as we mentioned earlier, the aorta is also going to be a high resistance vessel. So this is what a normal aortic waveform looks like. It's high resistance and it looks very thin. So this is an example of an aneurysm with atherosclerotic disease. And when you have an aneurysm and you interrogate in the aneurysm itself, you end up getting turbulent flow. So look how thick the waveform is here. So at any given time, there's a broad range of velocities. So this is what spectral broadening looks like due to the turbulent flow in an aneurysm, for example. You'll also notice that it's relatively low velocity. Not only is it low velocity, but it's also relatively low resistance. Look how high resistance a normal aorta is, and look how low resistance how low the resistance is here in an aneurysm. Okay, let's talk about the renal vasculature, the vasculature to a kidney. And so, the most common thing that you're going to see clinically with ultrasound when you're interrogating renal vasculature, again, depending on where you practice, is generally going to be renal transplants. But most of these principles apply to vascular ultrasound in native kidneys as well. For those of you who haven't looked at many renal transplants before, at first renal transplant ultrasound can feel a little bit complicated. There's you think there's a million things to look at, but it's actually not that bad if you break it down. So if you think about what's connected to the kidney, you have an artery that feeds it, you have a vein that drains it, you have a collecting system that drains the urine, and you have the kidney parenchyma itself, and then you have the space around the parenchyma. And so those are kind of the 5 categories of things that we look for when we're looking at a transplant kidney. And I've also listed the most common abnormalities that we generally see in those regions. So in the renal artery in a transplant, most commonly we're going to try to detect renal artery stenosis. In the renal vein, we're going to try to detect any renal vein thrombosis. When we're looking at the kidney parenchyma itself, we're looking for abnormalities that suggest things like ATN and rejection, and we'll talk about that in a bit. When we look at the collecting system, we're looking for abnormalities, specifically looking for obstruction. So we're looking for hydro, as we would in any kidney we're looking at. And then we're also looking for peri-transplant collections, like most commonly early on we get hematomas around the kidney. But again, the focus is not renal transplant in general here, but I did want to briefly kind of go over a broad approach. But let's look at each of these in turn. So let's first talk about what a normal renal artery looks like in a transplant or even a normal renal artery. So a normal renal artery should be low resistance, and we've looked at a bunch of waveforms here, and this is a low resistance waveform. And so you'll also notice that the peak systolic velocity in the vessel is lower than 200 centimeters a second in all locations. If we look at a patient who has a transplant and a stenosis, so this is a patient with proximal renal artery stenosis, and this is the anastomosis between the iliac artery and the renal artery, and that is the location where you most commonly get renal artery stenosis. And so you'll notice right away that the peak systolic velocity is quite a bit higher. So the peak systolic velocity here is 305.7 or about 306 centimeters per second. That's well above 200 centimeters per second. So that's a direct sign of renal artery stenosis. What do we look for when we're looking to diagnose renal artery stenosis? Again, it's the same principles we've kind of gone over again and again. So we're looking for a higher peak systolic velocity. In this case, generally we use over 200 centimeters per second at the stenosis itself. And distal to the stenosis, we're going to see, obviously, a tardus parvus waveform. Okay, and how do we look distal to the stenosis? Well, we look at the renal artery at multiple locations, but in all renal transplant interrogations, we're also assessing the intrarenal or arcuate artery waveforms in the upper, inter, and lower pole in the transplant kidney itself. Okay, and so when there's renal artery stenosis, these waveforms in the upper, inter, and lower pole are going to have a tardus parvus appearance like this. Okay, so when we look at the renal vein, okay, so normally we should detect flow. So we see it with the color Doppler here in blue away from the transducer, and we see it below the baseline. If we have thrombosis, this first point here mentions that we're not going to see the renal vein flow, and that's in, assuming that the thrombosis is completely occlusive. But another indirect sign that we may see with occlusive renal vein thrombosis is shown down here. So you can imagine that if you're pumping arterial blood into a kidney and the blood can't get out through the vein, then obviously there's going to be a high resistance flow in the artery. And if you just had this one piece of information and you just saw a very high resistance waveform with actually reversed end diastolic flow here, then you wouldn't be able to necessarily make the diagnosis of complete renal vein thrombosis based on this one piece of information alone. There are other things that could cause that. So other things that could have this very high resistance waveform include a very high grade stenosis distal to where we're looking or where we're interrogating, a renal vein thrombosis as we mentioned, or even a really big collection that's kind of around the kidney or subcapsular that's compressing the parenchyma. And as a result, the renal artery is pumping into a very high resistance situation. Okay, and so lastly, the kidney itself can have an issue, whether it be ATN, transplant rejection, or drug toxicity. It's often non-specific, but remember how I said we assess the upper, inter, and lower pole intrarenal arcuate artery resistive indices? Well, if there's disease in the kidney itself that's just distal to these arcuate arteries that's feeding the parenchyma, you're going to end up with high resistance waveforms in the upper, inter, and lower pole. And so normal RIs that we most commonly see in kidneys or transplant kidneys are about 0.5 to 0.7. That can vary, but that's the general range. If it's over 0.8, that's associated with some sort of renal dysfunction in native kidneys and in transplant kidneys. So when you have a transplant kidney, we always look at RIs in the upper, inter, and lower poles, and we interrogate and follow the resistive indices over time. And so this example here is an example of, you can see the kidney parenchyma, so this is an arcuate artery. You're actually interrogating over where the kidney parenchyma is. This is an extremely high resistance waveform. You can see there's no, or even potentially negative, but no end diastolic velocity or diastolic flow in the positive direction. So this is an RI of about 1. Now let's move on to the liver. And as I mentioned earlier, this one is going to be a little bit more involved since the vascular supply in the liver is a little bit more complex. And so we're going to talk about the hepatic artery, the portal vein, and then the hepatic veins. And we're going to show you normal waveforms and common abnormalities that you need to look for. And so the easiest of these is the hepatic artery. So the hepatic artery is similar to the other low resistance arteries that we've talked about, like the renal artery. So this is what a normal hepatic artery looks like. So we have a brisk and quick upstroke, and then it's a low resistance type of pattern with quite a bit of forward and diastolic flow. And the most common complication that we're going to see, for example, in a post-liver transplant is hepatic artery thrombosis and stenosis that can lead to that thrombosis. And so what would you expect with a stenosis? Well, first, at the level of the stenosis itself, we should expect a high peak systolic velocity. As you can see, there's a very high peak systolic velocity at the level of the stenosis itself. And what about distal to the stenosis? What do we expect to see distal to that stenosis? So yeah, we'd expect to see a tardus parvus waveform. So notice it's not a brisk upstroke. There's a longer time to peak. Okay, it's very low resistance and it's relatively weak in comparison. So this is a tardus parvus waveform with a lower RI. So the hepatic artery normal resistive index is about 0.55 to 0.7. So the RI in a tardus parvus waveform distal to a stenosis is actually going to be lower than 0.55 as shown here. Okay, and again, don't remember these numbers. It's again the same principles we've been talking about with stenoses. Okay, so let's talk portal vein. So the majority of blood that's going to the liver is supplied by the portal vein. Okay, so what does the normal portal vein look like on Doppler, and what does the spectral Doppler waveform look like? So here we have a normal portal vein. So you can see in the color interrogation window, we see red, so that is towards the probe. So we have flow that is going towards the liver in a normal portal vein. Okay, and you can see that if we interrogate that with spectral Doppler, as we have here, we get a waveform that looks like this. And this is what a normal portal vein waveform looks like. So what are we seeing here? Well, first, we're seeing that there is continuous forward flow. Okay, it's moving towards the liver continuously. It's all above this line. It's all above the baseline. Okay, and the term that is often used to describe blood moving towards the liver is hepatopedal flow. Okay, and think about it as blood pedaling, biking or pedaling towards the liver in normal situations. Okay, the second thing we're seeing is that the velocity is about 15 to 30 centimeters per second. So it's relatively low velocity. It's also biphasic, okay, which means that there's slight variability. Okay, so it goes up, then slightly down, then slightly up, then slightly down. That's that biphasic nature. And so over time, you see these undulations, okay? And those undulations or this variability that we see has to do with cardiac and respiratory pulsatility / variation, respectively. So cardiac pulsatility and respiratory variation that are transmitted through the sinusoids are going to result in this variability. And this variability should be slight. So the variability from the highest point to the lowest point should be less than 15 centimeters per second. Okay, but if you remember two things from this slide, it's that a normal portal vein should always be going forward. It's above the baseline always. And it's biphasic with slight variability, in other words. Okay, so if that's what a normal portal vein looks like, or a normal portal vein waveform looks like, what are common abnormal waveforms that we might see? Well, we said that normal flow in a portal vein is always hepatopedal or always towards the liver. Well, any reversal of flow, any flow in the opposite direction is abnormal or is considered abnormal. We also said that the velocity is generally about 15 to 30 or 16 to 31 centimeters per second. So slow flow is also abnormal, and that's flow that's less than about 15 or 16 centimeters per second. We also said that normally there should be slight variability, and the variability should be less than 15 centimeters per second from the highest to lowest point. So we might also see an abnormality where the flow looks very pulsatile. So the difference between the highest point and the lowest point is greater than 15 centimeters per second. And then obviously, if you had completely absent flow, so slow flow that it's absent, that would also be abnormal. And so what do these abnormal waveforms mean? Well, there's only a few things that we generally see, and so these are the abnormalities that correspond to each of these things. So the first, any reversal of flow, is diagnostic for portal hypertension. Okay, and you're most commonly going to see portal hypertension with cirrhosis, but obviously there are a bunch of causes of portal hypertension. The second here is the peak or highest velocity is less than 16 or 15 centimeters per second. And that is also suggestive of portal hypertension, again, most commonly with cirrhosis. You can have very pulsatile flow, and most commonly we see very pulsatile flow due to the bolded causes here, so tricuspid regurg and right heart failure, aka cardiac causes. You can also less commonly see it with various shunts in the liver, so you get arterial portal shunting in cirrhosis, for example, or an AVM, which is rare. But the most common situation is increased pulsatility as a result of a cardiac issue. And then lastly, we have absent flow, and that's commonly seen with thrombosis, but this is also key that absent flow or the lack of flow doesn't mean it's thrombosed. You can also see that in portal hypertension. So if the flow is so slow that it looks like it's absent, you can also see that in portal hypertension. So no flow doesn't mean thrombosis, but you need to think of these potential causes. And so let's look at a few cases in the portal vein and apply these principles. So this is the first case, so have a look. So here in the color Doppler picture alone, we can see that the portal vein, this is the main portal vein that's labeled here, that's what MPV means. So the main portal vein has flow that is blue. So it's actually away from the transducer, and that's abnormal. If we look at the spectral waveform, we see that all of the flow is below the baseline. So this is all retrograde flow, or flow in the wrong direction. This is hepatofugal flow, not hepatopedal, not pedaling towards the liver, but hepatofugal flow, or away from the liver. Okay, and so this is an example of, as we showed earlier, portal hypertension. Again, most commonly you're going to see this with cirrhosis. What about this second case here? So here again, this is the main portal vein, and it's red, which we would normally expect. But if we look at the spectral Doppler tracing now that we've created, we notice that, yeah, it's mostly forward, but it's variable, and there is flow that's going below the baseline. Okay, and so there's still some reversal of flow. And remember, we were very clear on the last slide. We said that any reversal of flow is abnormal. Okay, and so this is a more mild case of portal hypertension. Okay, in the third case here, again, the main portal vein, have a look at it. Okay, and so this is showing us very pulsatile portal venous flow. Remember what the normal portal venous flow looked like on the last couple of slides, and remember the difference between the top and the bottom, or the highest and the lowest points, should be less than 15. Here it's way over 15, so I've labeled the top here, which is 42, and the bottom here, which is about 13. So the difference between those is 29, so it's very pulsatile flow. And most commonly you're going to see that with a cardiac cause, and here it was, or happened to be, tricuspid regurgitation. And so the last portal vein case here, what are we looking at here? So this is the portal vein here, and we see that there is a lack or absent flow distally here. And not only that, but you'll notice that the portal vein here looks patent, but then the vessel itself looks expanded, and it looks like there's stuff inside of the portal vein itself. So this is an example of portal vein thrombosis. The absent flow itself could be related to portal hypertension, so we don't know yet. But in this case, on the grayscale and in the other images, we saw that there's something inside of the vessel and it's expanded. And those are things you can look at to try to determine whether we're looking at a thrombosis or not. And so this is an example of portal vein thrombosis. Okay, and so that's it for portal vein talk. Okay, so we're almost done, but this is important. So the hepatic veins are probably the waveform that I see most commonly misunderstood or not understood well. So let's fix that. So here is a normal hepatic vein waveform. And the first thing to notice in this waveform is that most of the flow is antegrade. It's all below the baseline, okay? And so what does below the baseline here mean? Well, notice it's also blue, so it's away from the transducer, right? Away from the transducer, away from the liver, and towards the heart. The first thing to notice again is that most of the flow is antegrade or below the baseline in a hepatic vein. Okay, and the second thing to notice is that this is a very multiphasic waveform. And the reason why it's so multiphasic and moving in so many different directions, it looks like, is because of the proximity of what we're interrogating to the heart. And so the best way to think about this is think about the pressures and changes in the normal right atrium. Okay, so it's multiphasic. Okay, some people use the word triphasic, but it's actually quadriphasic. Okay, so there are 4 total phases. And in those, there are 2 large antegrade waves, okay, and antegrade again flowing towards the heart, and that is this hump here that is labeled S for systolic, and this wave here that is D for diastolic. And then we have 2 smaller retrograde waves, okay, and those are one just before the systolic antegrade waveform with the A labeled with the A here, and that's A for the atrial kick. Okay, and then we have another one that's labeled V here that's just after the systolic antegrade hump. Okay, and that is due to atrial overfilling, and we'll talk about that in a bit. So in a normal situation, it's good to think about this in order of the physiology, and when you're reading it, you don't think about it, but it becomes second nature. But essentially, if you go through a cardiac cycle, you have the atrial kick, and that results in retrograde flow, usually, so back towards the liver for a very brief amount of time. And after the atrial kick, you have systole. And so in systole, the AV valve or the tricuspid valve is closed in normal situations. And so as a result, you have a lot of blood that's moving into the right atrium or filling the right atrium. And so that's what the S is. It's during systole filling of the atrium. And so much blood rushes in that eventually, against a closed valve, the atrium is going to start to become overfilled. So the filling is going to start to slow. And then the V refers to the valve opening. And when the valve opens, the ventricle and atrium are now in contiguity, and blood can go into the ventricle. So when the blood goes into the ventricle, the atrium can now fill more so. So in diastole now, the D, you have a second hump where there is even more filling of the atrium, and you have more antegrade filling of the atrium. And so that's where you get the atrial kick, systolic filling, overfilling of the atrium, and then the valve opens, and then you can fill in diastole a little bit more, and then you have a repeat. So you have another atrial kick, and then systole, overfilling, valve opens, diastole, and then again the atrial kick again. So if that's confusing to you and it's hard to keep the cardiac cycle straight because it's been a while since we've done cardiology, just remember again, predominantly antegrade, multiphasic with 2 large antegrade waves and these two smaller retrograde or in the retrograde direction waves. And so in normal situations, we don't conveniently have all of these waves labeled. So we have to often find a landmark to try to figure out where we are in a normal waveform. And the way that I do this is I look for the A wave. Okay, and the A wave is what you're always going to look for to orient yourself. And so in normal situations, the atrial kick that's shown here is the maximum retrograde wave, so above the baseline. So in normal situations, it should also be above the baseline. And you might say, okay, well, the V wave can also be above the baseline. Here it's not, but it can be. And how do you differentiate the V from the A? And the way you do that is that the A wave is wider and taller than the V wave. Okay, and even in pathological states, that holds true. So the A wave remains wider than the V wave. Okay, and again, if this makes no sense, don't worry. We'll talk about what you need to know in a bit. But this is just if you want to truly understand these waveforms. Okay, so if you understand that, then let's look at what happens when things are abnormal, and let's keep it simple. So to simplify, let's put it this way. In general, you can categorize abnormalities that we're going to see in the hepatic venous waveforms or in the hepatic veins into only three groups. Okay, you can have increased pulsatility, so really big fluctuations that are more than the normal amount of fluctuation. You can have, number two, decreased pulsatility, so less fluctuations than normal. Or you can have absent hepatic venous flow. So keep it simple and we'll go through these three categories. So let's start with what would cause increased pulsatility or increased fluctuations. Well, as we mentioned earlier, what we're seeing in the hepatic veins is a reflection of what we're seeing in the right atrium. So things that are wrong with the right heart are going to make things very pulsatile. So the two most common things that are going to cause increased pulsatility are tricuspid regurgitation and right heart failure. And to be honest, in clinical practice, it's really just your job to recognize that the waveform is abnormal and then suggest that it has a cardiac cause. But let's try to understand the theory and understand how to figure out if it's tricuspid regurg and what it looks like, or just right heart failure without tricuspid regurg. Okay, so this is tricuspid regurgitation, and so what is that? So tricuspid regurgitation is essentially an issue with the tricuspid valve. So during systole, the ventricle is going to be pumping blood forward into the lungs, but it's also pumping blood that's going through an incompetent tricuspid valve and going backwards through the tricuspid valve and into the right atrium, and then that's reflected in the hepatic veins. So the systolic wave, that this is a problem during systole, is going to be decreased or reversed. So that's key. That's all you need to know for tricuspid regurgitation. The S wave is going to be decreased or reversed. So in this picture here, we have the A here, the atrial kick, okay? And that's a broader or wider retrograde portion, not like V, it's very sharp, but the A is very broad as we mentioned. And then we have usually in a normal situation a big systolic antegrade flow here, but instead there's a significantly decreased systolic antegrade component here. So this is abnormal. This is what we'd expect to see with tricuspid regurgitation, okay? And if it gets so severe that the tricuspid regurgitation is actually backwards, or the S wave is significantly backwards, what happens is that the A wave, the S wave, and the V wave all just meld into one. And so we call that wave here, it's labeled here, the ASV wave. Okay, and so really you only have two waves here. You have a retrograde ASV wave, and then diastole you have forward flow. And so this is a typical appearance of more severe tricuspid regurgitation. Okay? If that again makes no sense, just remember increased pulsatility, cardiac cause. Here's a second case. So this is what you see in right heart failure without tricuspid regurg, so a normal tricuspid valve. But of course, in real situations, you can have them together. You can have right heart failure with tricuspid regurg, and it can muddle the picture. But here, this is what we'd expect with right heart failure and no regurgitation. Okay? So in pure right heart failure, the issue is that the right atrium is filled with blood all the time because the right heart isn't pumping well enough. So you're going to get big retrograde A and V waves. Okay? So that's the hallmark of heart failure. These A and V waves are bigger and retrograde. Okay? The right heart is not pumping well. The right atrium has a lot of blood in it. And so when you have an atrial kick, you're going to get a lot more backwards. And you're going to get overfilling relatively early. So there's going to be a big V wave as illustrated here. Okay? And you still have forward systolic and diastolic flow. If you also had regurg, again, we'd expect this systolic wave to look smaller or eventually reversed. Again, that's the minutia. If this didn't make any sense, it's cool that you've gone through it and all, but again, it doesn't matter. In clinical practice, just recognize increased pulsatility. That's cardiac congestion, a cardiac cause. What about situation 2 or scenario 2? And that's decreased phasicity / pulsatility. To simplify, we're talking about less fluctuations. And so most commonly, you're going to see that in cirrhosis. Okay, you can see it in other things like hepatic vein thrombosis or Budd-Chiari, but if you remember one thing, decreased pulsatility, by far most commonly you're going to see in cirrhosis. And let's look at what that might look like. So again, here we have the normal waveform, a broader A wave, systolic filling, the V wave here, and then the diastolic filling antegrade. If we have decreased pulsatility here, you'll notice that again, we still have our A wave, S wave, V wave, D wave, but there's decreased pulsatility, so they're less defined for one. And for two, notice that the A wave is no longer retrograde. It's not above the baseline. The A wave is below the baseline. So an A wave below the baseline is technically abnormal. And this is a subtler case or more subtle case of decreased pulsatility. Okay, and then lastly, a more severe case with completely non-phasic and non-pulsatile flow here. This is obviously abnormal. Okay, and lastly, for the hepatic veins, you're going to have absent hepatic venous flow, which occurs with outflow complete obstruction, most commonly with thrombosis or Budd-Chiari. Okay, so let's go through a couple of cases. So the first one here, we're looking at the hepatic vein here, and we have this waveform down here. Okay, and so what are we looking at? What do you guys think about this waveform? Okay, so if the first thing you notice is that this is pretty pulsatile, you'd be correct. So this is likely a cardiac cause of this abnormality. And if you look at this waveform and you were paying attention in the last little bit, you'll recognize that this is the classic appearance of tricuspid regurgitation. So we have a retrograde ASV wave that's all bunched up into one here, and then anterograde diastolic flow here. That systolic filling should usually be down here where my mouse is, but it's actually reversed and it's kind of all melded into one here. And the second case here, so we have clearly a very small liver that looks coarse, abnormal with ascites around it, and then you have a hepatic vein with complete loss or decreased in the pulsatility. And so this is a case of cirrhosis, of course. This is something you might see in cirrhosis. And so usually you know the patient has cirrhosis, and then you happen to see this waveform as well. It's rare you're going to make that diagnosis alone based on that, at least in my experience. Okay, and so that's it for the liver and for the hepatic vein. So you've gotten through the kind of most involved or hardest part of this talk. Okay, and so briefly, in other parts of the body that you might look at, this is what a normal testicle looks like. So the normal waveform in the testicle, that's after puberty at least, should be relatively low resistance. And in patients with torsion, you often have a complete absence of flow or no flow in the testicle itself. But earlier on or with a lesser degree of torsion, you may have some flow. And so some flow doesn't exclude torsion. That's key. Some flow does not exclude torsion. So the spectral Doppler can be helpful in this case. I mean, the most helpful thing is actually just comparing the testicles in that first paired view. But if you look at the waveform as well, you can see that we have clearly a weak and slow upstroke here. This is a tardus parvus waveform. If we're talking about torsion, then the issue is proximal to what we're looking at. So currently we're interrogating downstream of the essential stenosis / torsion. Okay, another application that we're not going to show you here, in epididymitis orchitis, obviously you're going to get increased Doppler flow on the color. But specifically speaking of the waveform, when you have orchitis and you look at the waveform itself, the one clinical thing to take away is that a high resistance waveform or a very high resistance waveform can be a negative prognostic indicator. It's essentially a bad sign that can suggest that there's a very high risk of infarction of that portion of the testicle. Okay, and so lastly, as we continue to move down, let's talk briefly about Doppler in the lower extremities. So in a normal extremity artery, we're going to see high resistance flow as we'd expect for the reasons we described earlier. In a normal extremity vein, like the femoral vein, for example, we should be able to detect flow. And you're also going to see some variability over time, and that's related to the respiratory and cardiac variability as well. And so we don't have too much time to talk about deep venous thrombosis or DVT detection. That's kind of a basic ultrasound skill. That's not the purpose of this topic. But let's talk about specifically looking at using Doppler in extremity arteries in specific clinical situations. So let's look at a case to illustrate this principle. So this is a patient who had a previous arterial puncture. And so we ultrasound the right groin, and this is the picture that we have here. And so this is a color Doppler picture. And it's not shown well here, but we have a kind of femoral vasculature back here. And then we have this anechoic region on the grayscale or B mode ultrasound. And we look at the color Doppler and we get this specific appearance. So what are we looking at here? So this is a classic appearance of a pseudoaneurysm on a color Doppler. And this sign that we're seeing here is called the yin and yang sign. So it looks like a yin-yang, okay? And it's due to blood swirling in this pseudoaneurysm. So you have an aneurysm neck, and then you have kind of blood moving in this direction in part and then away in the other part. So you end up getting kind of blood towards and then away in the sac, and you get this classic yin and yang appearance in the aneurysm sac or in the pseudoaneurysm sac itself. And then we have a spectral Doppler classic sign of a pseudoaneurysm. And specifically, when we're looking at spectral Doppler, we want to interrogate the neck of the pseudoaneurysm, not the sac itself, but we want to look at the neck of the pseudoaneurysm. And the classic appearance at the neck here that we're seeing is called the to and fro pattern. Okay, and that refers to blood that's going into first the pseudoaneurysm sac and then away and out of the sac, in systole into the sac and in diastole out of the sac. So that's the classic to and fro pattern that we see at the neck in pseudoaneurysms, and those are the two classic signs that you're going to look for on a Doppler interrogation to diagnose a pseudoaneurysm. Okay, and lastly, while we're talking about arterial punctures, just one more case. So it's the same history, previous arterial puncture, but a different patient. And here we're interrogating using spectral Doppler. And actually, if you look at the label, we're actually looking at the common femoral vein here. This is a vein. But you'll notice that this doesn't look very venous. It looks very pulsatile. And so this is very pulsatile flow in this vein. There's more abrupt upstrokes than usual in a vein. And if we looked at the artery in this same case, normally we'd expect the femoral arterial vessels to have a high resistance flow. But let's say we look at the artery and we notice that it's a low resistance flow in that artery. So what's going on here? So this is the classic appearance, or what you would look for to diagnose an AV fistula. In other words, your puncture created a connection between the artery and the vein. And so as a result, as you'd expect, the arterial pulsatile flow is transmitted into the vein, and you're going to see pulsatile flow in the vein like we see on the left here. So that's one sign. And if you looked at the artery, right, usually it's high resistance, but because the arterial flow can follow a low resistance path into the vein itself, we're going to see a lower resistance flow in the artery itself. So that's what we're going to look for in an AV fistula. And so that's it for this talk. We went through the basic principles at the start of this talk, and so that's what I really want you to walk away with from this talk, those basic principles. And then we went from head to toe, and we showed you normal waveforms, the classic appearance of normal waveforms throughout the body, and then abnormal waveforms as well. Okay, and again, focus on the big principles. I hope it helped. Click on the specific times if you want to go back to specific areas, like if you want to remember what liver Doppler looks like and you want to know what the hepatic vein waveform looks like, you can always go back. Okay, and so that's it for now, and thank you.